Yes, we can hear you very well.
Thank you very much, Lois, and good morning to each one and every one of you. First and foremost, thank you for the invitation. I'm excited as well today to be part of this discussion. I did mention to you that we have a team that is visiting here to discuss from Italy, that is here to discuss with us how to deal with matters of healthcare, particularly in the area of mental health. And this team is with us, and I'm taking them to the Kenyatta University Hospital in half an hour or so. However, I really feel this is important for me to be here, if only for a few minutes, to do one or two things. The first one is to really thank you, because, you know, Kenyans, being a politician, I'm aware of what happens in Kenya, is that you can even get somebody a job or give somebody a loan. And the next time you meet them is when they are telling you whether you can help them to be promoted. They never even called you to thank you. So we are not people who are used to saying thank you. And therefore, I want to take this opportunity to just thank you all, really, from the bottom of my heart, and I mean it. Because from March of last year, when we had the bad news about the presence of COVID-19 virus in Kenya, you are right, Dr. Achieng, that we got together. You were there on that first meeting yourself. And the team from KU, the team from Kenyatta National, teams from Nairobi University, etc., etc. And you are right, all these days, and in subsequent decisions that we have made, we have never gone to make a decision without involving our health team. And you are right, we have always advocated making decisions on the basis of evidence and science. And that's what we have continued to do. And I can assure you that that is what we are going to continue to do. And on very few occasions, we actually deviated from your recommendations on the basis of the fact that sometimes, you know, there are other factors that we have to deal with. But by and large, I think that what you have advocated and what you have promoted is what we have done. Having said that, let me also thank you for leadership, because sometimes all these things happen because of leadership within case management team, and yourselves, Dr. Branura, and all the others. I want to also congratulate you for your leadership in these things. And you know, health matters in this country are not owned by one individual. Neither can they be led by one individual. In fact, some of us are very temporary in terms of healthcare management. You are the more permanent people, because whether it is CS Kagwe who is here, whether it is CS anybody else who is here, doctors, you'll still be here, nurses, you'll still be here. You are the more permanent fixtures as far as health management in this country is concerned. And for that reason, I would like to urge a few things. First is in terms of case management, I want to say one of the reasons why I was excited about this particular meeting is because from the word go, when I go out there and I meet people who have been to India, who have been to the UK, who have been to other countries, they tell me that the difference that they were seeing is that in this country, a patient is essentially owned by a doctor who does not recommend second opinions, who does not want you to see somebody else, and kind of feels that this is my patient, and every time you say I want to see somebody else, then it sounds like you are not confident about them. Whereas the practice, for example, in India, is that there is always a team of people discussing how to treat somebody, and therefore the rise in confidence. And this is, in a sense, a way of saying that is not true. Because this discussion, I mean, I don't even know in which country 400 or 1,000 people discuss how to deal with cases. So beyond even 2-3 doctors getting together, you are getting together as thousands of people. This is really commendable. This is very commendable. And it is also commendable because nobody is a custodian of knowledge. Nobody knows everything, including managing cases. Nobody can know everything. So the fact that you are willing to listen to each other, you are willing to share what you know is a serious move forward as far as healthcare in our country is concerned. And I urge you to practice it. Now that we are all used to virtual meetings, and as we head for what I call the e-theaters, I have challenged my team, Dr. Ching, I've challenged the ICT team to create the first e-theater and to be able to carry out operations virtually. In Kenya, we are launching the link between Isiolo and Kenya National Hospital, as you know, but I think we must think beyond there and look into the future and ask ourselves, how are we going to be doing business? How are we going to be managing cases? How are we going to interact with each other? How are we going to share these things in the year 2030? What is it going to look like? How are we going to be doing what we are doing now? Beyond discussing it, are we also going to be able to operate people? 2-3 of us, 2-3 of you, the way that we are discussing, and think this is where we are going. And if indeed that is true, then the third item that I think we need to look at and to think about and to debate about, and CS Magoha and I, the council and ourselves, the acting director general and ourselves have been discussing this thing. And the question is, what is going to be happening? What sort of curriculum should we have in the health sector, not just for doctors, for nurses, for other people? What sort of curriculum will inform an efficient, globally renowned healthcare worker in the year 2030 and beyond? What should we do? I was talking to Ouma, I remember last year, and I said, Ouma, we are all going to telemedicine and e-theaters and e-operations. How much does the healthcare curriculums, whether in KMTC, whether in University of Nairobi or elsewhere, how much ICT have we infused, in healthcare training? And Ouma said none at all, which is quite surprising, knowing where we are heading. So I want to welcome you to start a debate on that matter, on the matter of, now that we know what we know, now that we are able to engage each other more, what is it that we can recommend to the government in terms of policy, in terms of curriculum, so that between the Ministry of Health and the Ministry of Education, they can get together, we can all contribute towards who is going to be the super healthcare worker in the year 2030 and beyond. Beyond there is my final aspect, which is that we must always keep remembering that we have got a devolved system in Kenya. The healthcare system is devolved. And therefore, in terms of healthcare management, we must never lose sight of the fact that a lot of work needs to be done at the county levels. And I know that the counties have been criticized and so on. But one thing we can confirm now, and I can say this without fear of contradiction, is that the capacity that we have built in the counties would never have been possible were we just managing this thing from Afya House, all the way into Ghana, all the way into Garissa, Mandela, Kakamega, Kajiado. I can say without fearing that I do not believe that managing this thing from Afya House, we would have been able to do what we have done. And therefore, I want to confirm that I'm a believer in the issue of devolved government. Now, having said that, we have also learned that one cannot do without the other. We have learned that it is very important that the national government has, in terms of policy, has a bigger say and a bigger influence than has been estimated in the past. And when it comes to a national crisis, then the role of national government is obviously also higher than perhaps we would have expected. The other point also is that in terms of equipping our hospitals, in terms of some of the bigger infusions of efficiency and into healthcare, it is now clear, for example, with the MES project, that it was probably handled badly the first time round, but it is now clear with what has been going on that some of these changes, if they are going to be run efficiently, must probably be looked at a national basis to scale up rather than on a county basis. But we must never lose sight of that fact. And we must always, again, think through how will the future relationship be between healthcare at the county level and healthcare and policy as a national activity. So, Dr. Aching, you said that you can tell us a few things to rephrase what you say, that you can say quite a few things. I can also say quite a few things. I'm passionate about what I'm hearing and what I'm seeing within the Ministry of Health. I'm passionate about the reforms that are currently ongoing, and there is a lot happening on the ground. But more importantly, is that I'm seeing increased confidence in our healthcare workers as far as the general populace is concerned. Let's always remember my last statement, that whatever we do, and I've said this before, and I want to repeat it again, by the end of the day, whatever we do, whatever activities we carry out, let us never forget that ultimately we want to put a smile on a patient's face. That's the long and short of it. Doesn't matter what we do, doesn't matter whether we build offices, doesn't matter whether we buy cars, all of it is supposed to be aimed at only one thing. Treat a patient, they get better, they feel good, and they smile. That's it. It's a long and short of it. So if we remember that, then a few things then become important. The non-clinical issues, when you are managing a case, remember there is a non-clinical issue. There is the issue of sending that person home feeling good, and sometimes people are so vulnerable. They are so vulnerable and so scared that they are looking at you, not just as a doctor who is going to save them and to save their lives, but they are also looking at you as a person who is going to comfort them. So, and that's the non-clinical issue I'm talking about. Let's never forget that one. It is very, very, very important. And I can tell you that as a as a non-doctor, a non-clinical professional, but I can tell you that from a patient perspective, we all expect you to make us feel good. I thank you all once again, and I wish you deliberations. I will be visiting you here, every so often as much as I can. And perhaps, who knows, I might pick up one or two things and treat myself instead of coming to you again. Thank you all very much indeed.
Thank you so much, CS. Allow me to ask you one question, please. It's a question that's on many healthcare worker minds because our patients and the population is asking us this question. And maybe just a word to all of us on what we can expect with vaccines. Everybody's wondering, so I got my first one, I'm stuck. Is there any hope for me getting vaccine? What can we expect?
Okay, let me say what is on the table right now. As you know, we have vaccinated approximately nearly 600,000 individuals with the second dose of the AstraZeneca vaccine. I can confirm here now that there is no fear about whether we are going to get sufficient AstraZeneca doses for the second dose, because we will be announcing soon the receipt of some 410,000 doses from the UK. So it is not public. It is not out there in the public yet. We are still resolving and the agreements and so on. But that can be expected. The second thing is that we are also expecting some other doses from Europe. Greece is one of the other countries that we are also expecting doses from. As a matter of fact, our issue now is we might even have more doses than the 1 million that we are looking at, which means that this time round, and because they're expiring, they're expiring in the year, we can't really use them for the second dose. However, and I think this is something you should be discussing, because globally now, there is this growing acceptance that perhaps a mix in the vaccines may not be such a bad idea. This is something that we expect you to come back to us and to advise us and tell us. The second thing is that under the COVAX arrangement, we are also expecting through the United States has given us about 1.8 million Pfizer doses that we are expecting in the month of August, that is next month. And in addition to the 8.8 million doses that they are giving us, we have also bought some 6 million doses of the Pfizer vaccine. We are also expecting our own, what we have purchased for ourselves, some 13 million doses of Johnson & Johnson, the Johnson & Johnson vaccine. And as you know, that is 13 million people. And also, in addition to that, there is also contributions of Johnson & Johnson that we are all expecting from the COVAX arrangement. So in addition to 3 things that we are getting, we are saying that's all very nice, yes, let them come, but we are not relying on 3 things. You know, we are out there, we have booked additional doses for the Johnson & Johnson. But let me also add here that you might not know this, but we also now are fast tracking the plant that we are going to have. We are calling it the Kenya Biovax, which is going to build the fill and form plant. This we have already located. That the fill and form plant is going to be at Kemsa, where industrial area, where we have near the airport, where we have got the go-downs, 2 go-downs that we have identified for that purpose. So, and there is a team led by Dr. Kanobinda, who is the chair of KEMRI, who is the one who is heading this team to implement the vaccine plant that we want to have for ourselves in this country. And it is surprising to me, actually. I was very surprised when I visited the plant, the vaccine plant, the livestock vaccine plant in industrial area, and asked myself, for 30 years, we have been producing livestock vaccines and selling them. But I think we like our cows so much that we developed vaccine making capacity for livestock, but forgot about ourselves, which is a little bit surprising. Now we want to change that and be capable of producing our own vaccines. Now the plant, the Kenya Biovax, is not going to be a plant just for COVID-19, for Johnson & Johnson. We are going to work with the Johnson & Johnson, yes. We are going to work directly with Johnson. We are going to work with the Aspen Institute in South Africa to grow big as far as vaccine production is concerned, not just for Kenya, but also for the region. I know that there has been a lot of noise, people claiming they are launching this, others are talking about making vaccine. We prefer to work quietly behind the scenes and just produce and be practical about what we are doing, rather than making a lot of noise out there and actually producing nothing. So I don't know whether that answers the question, Lois, but that's where we are. We are working very hard and very fast. The team that is working on this is also working very hard at it. It includes a number of people, including people like, as I say, Dr. Binda, who is the chair. We have got others from the ministry. We have got others even from the vet making plant in Nairobi West. So all in all, there is a lot happening. We hope that it crystallizes very quickly. We see no reason why it shouldn't. The cabinet made a decision that we are not even talking about borrowing money for this plant. We allocated money for some 2 billion shillings to deal with this issue of the form and fail plant. The team is already looking at where to source it from. We obviously want to discuss very closely with Johnson & Johnson, because that's the vaccine we are going to make here. That's the vaccine we are going to produce in the country. So going forward, I am hopeful, and I think that we can expect that we are going to be sufficient, self-sufficient, in as far as vaccine production is concerned in the coming few months for the form and fail, and few years for the actual production of vaccines. Hopefully we are not there. Some of us will make sure it happens. Some of you will make sure that it happens.
Thank you so much, CS. I think that gives us a lot of hope, and we can now talk to the communities and to our patients, because from the volumes of vaccine coming in, it seems almost all adults, there'll be a vaccine available for all adults in the country, which is very, very encouraging. I think one of the things you mentioned about the work between both the devolved units and the Ministry of Health has played out very well in this platform. We've had presentations from Turkana, Wajir, Kilifi, Malindi, Kisumu. All the counties in the country have really logged into this platform, and we've had an opportunity to really discuss patient care. I really acknowledge my colleagues who supported this work, Dr. Thuranira, Dr. Maritim, Dr. Nyukuri, who've been here consistently almost every week for the last more than 1 year. This platform is hosted by the Kenyatta National Hospital, and I'm very happy that our CEO, Dr. Kamuri, is here today. Dr. Kamuri, if you'd kindly unmute yourself and just say a word of hello.
Thank you, Lois, and thank you, Waziri, for giving me this opportunity. I'm sorry, my network is not very good. I'm in Othaya. On Fridays, I run Kenyatta at Othaya. And I would only say thank you very much, Waziri, for the support that you have given us. COVID has really taught us a lot. And one of the things we can tell you for a fact is that, as you've said, nobody can work alone. In COVID times, we have discovered the University of Nairobi, Kenyatta National Hospital, we are joined by the West. And we have really been managing this pandemic in a very collaborative and supportive effort. And also the ministry has been very supportive, and we promise that going forward, we will actually join hands even in managing other issues regarding the health systems in Kenya. We are also grateful that the referral system is taking shape now. We can assure you that now we are going to reform Kenyatta in terms of even cleanliness and clinical outcomes, because now we have the numbers that are coming and we have the expertise. And we promise you that now we only need support to improve the technology, especially if we go to the direction of ICT. We need so much support, Waziri, so that we can give Kenyans what they deserve. Thank you very much, Lois, for giving me this opportunity. We'll continue supporting and doing what we are supposed to do. Thank you. Lois, I hope I was clear.
Yes, Dr. Kamuri, we had you. We lost you at the end, but we've had most of what you said. Thank you very much. And CS, one of the initiatives of the ministry is around providing oxygen for facilities. And over the next 1 month, we have committed to doing training on how to use oxygen for all the clinicians, so that whichever hospital a patient lands in, they're able to safely treat that patient with oxygen. And today we are going to start the series on oxygen training that will go on for the next 1 month. So thank you very much for joining us. I know you're dedicated. We need to release you.
That is really exciting to hear that about that training, because as you know, if you look at, and I think sometimes we should really pat ourselves on the back and pat yourselves on the back. If you look at the capacity for infectious disease management that we had in March of last year, and you look at the capacity that the country has today, it is almost like every county has a higher capacity than the country had at the time that, at this time last year. And that's a lot to do in a period of 1 year. If you look at Nairobi and the 19 hospitals that we have built over 1 year, I think that's it's an unknown phenomena in the country. And it is you people who are making it happen, because, for instance, when we opened one of the hospitals, I think it was Uthiru. When Uthiru was opened, within a day, the place was packed with people. And to Kamuri's point, that is what is going to help Kenyatta to become a real referral hospital. The opening of what we are calling the Margaret Uhuru Hospital, the Korogosho, otherwise known as Korogosho. You know, you can't call a hospital Korogosho. Who can believe that they can get better in Korogosho when you're being Korogoshoed? So we have changed that, and we're in the process. I hope she agrees. But we have asked that to be called Mama Margaret Uhuru Hospital because of her work in the healthcare sector. So I'm very excited. At the end of this month, I'll be going to MTRH to launch perhaps the biggest single oxygen plant in the country, a 2,000 liter per minute production. That is more capacity than we probably had at the beginning. We are looking at Kenyatta itself, coming up with even a bigger one than that one. And the idea is that at every point in the counties, there is no county that should be relying entirely 100% on oxygen supplied from elsewhere. We have also seen how important it is to deal with more leasing than buying, the difference between equipment when it comes to managing equipment. For me, what I have seen now is that leasing is always so much more efficient than buying. We are not against counties that make a decision to buy. It's up to them. But for me, from what I have seen and in terms of equipment management, all the MES projects, I've gone around looking at the MES projects and they are all operational. And every time I visit a hospital, and I have visited many, you still see a huge equipment sitting on the side. And if you ask what happened to this one, what is this? Oh, it's an MRI machine. What happened to it? Oh, it has not worked for the last 1 year or 2 years or 3 years. Why? Or there's a bolt missing or something like that. The classic example for me, Ching, was the helicopter, the ambulance, the helicopter ambulance that sat in the Wilson Airport for 30 years, 30 years. It flew 500 miles and sat, and then something missed out or some little thing missed out, and that was that plane, that ambulance sat in Wilson Airport for 30 years and wasted away. It cannot be fixed now. It's too late. It's gone. But for 30 years, it sat there because of the manner of purchase. Had it been leased, it would never have gone through the way it went. So again, these are things to think about. Yes, I know we are discussing case management, but I think the curriculum, I mean the discussion around healthcare, it cannot be discussed. Nothing in healthcare can be discussed without the involvement of the people who are in this forum. So sometimes it will be also good to take it aside and discuss some of those things. Thank you all very much. I really have to dash, but I just want once again to thank you all very, very much and really urge you to continue doing what you're doing. And when there are issues, let's always try and resolve them, because at the end of the day, the only way anything is resolved is by talking. So let's continue doing that. Thank you all very much, and particularly thank you, Dr. Ching.
Thank you very much, CS. It was our honor to have you today, and we look forward to hosting you another time. So panelists, please unmute yourselves. Let's clap for CS.
Thank you.
Thank you so much. Okay, to everyone else, thank you for joining in. Today, we are starting our series on oxygen therapy. Our first speaker today is Dr. Ann Mugera, who's a critical care specialist at the Kenyatta National Hospital. She'll be taking us through the basics. What is oxygen? Where do we get it from? What are the indications? What is respiratory failure? Beyond today, we will have other sessions on identifying patients who require oxygen, how to deliver oxygen, which device is appropriate, when to use what device, how to monitor a patient who is on oxygen, how to wean off, how to step up, and advanced respiratory support for patients who fail to oxygenate. So it's going to be an interesting next 1 month, and we hope you'll be able to join. Encourage people, especially who are managing patients who may require oxygen, to join in. These sessions are recorded, and this material will be available so that it can be shared as much as possible. So Dr. Ann Mugera, welcome to the session. If you're able to unmute yourself and share your screen, then you can go ahead.
Hello, can you hear me?
Yes, we can hear you very well.
I'm
if you
sharing
could
my
do
screen.
slideshow.
Let me know. Yep. Can you see my screen?
Yes, we can. You can go ahead.
So thank you for inviting me to share about the basics of oxygen and oxygen therapy. And forgive me if I oversimplify this, but it's just a reminder of things that we already know. So what is oxygen is what we're going to talk about today. The difference between the oxygen in the air and the medical oxygen. We'll try and identify our sources of oxygen. We'll try and recognize hypoxia and hypoxemia, pulse oximetry, indications for oxygen, and identify the devices that are needed. So we'll start with a little quiz. And I want you to just get a pen and paper and try and answer these questions, and hopefully we'll be able to answer them by the end of this session. So when a person is breathing air, not receiving supplemental oxygen, that is, how much air do they breathe? How much oxygen is in that air? Is it 100%? Is it 50.8? Is it 99.8? And is it 20.9? What is hypoxia? Is it A, decreased oxygen concentration in the tissue? Is it infection caused by bacteria in the lungs? Is it a bluish tinge to the skin or other tissues? Or is it decreased oxygen concentration in the blood? What's hypoxemia? Is it decreased oxygen concentration in the tissue? Is it infection caused by bacteria in the lung? Is it a bluish tinge on the skin or other tissues? Or is it decreased oxygen concentration in the blood? And then the final question is, which is the most common and non-invasive way to measure a patient's oxygenation? Is it an arterial blood gas analysis? Is it pulse oximetry? Is it venous blood gas analysis? Or is it continuous positive pressure ventilation? So I would like you to keep those in mind as we go through this session. So what is oxygen? Basically, it's a natural occurring, colorless, odorless, tasteless gas. It's very essential for normal cell metabolism. So all cells require it. Remember, in air, we have most of it is nitrogen, 78%. Oxygen is only 21%. Then other gases is 1%. So the air that we breathe is approximately 21% of pure oxygen. Medical gas, however, is at least 82% pure oxygen and is free from all the other gases like the nitrogen and the other gases that we find in air. So what are the sources of oxygen? So medical oxygen can be available in multiple formats. It can be cylinders, it can be oxygen concentrators, or you can have central piped oxygen. Now, central piped oxygen can come from an oxygen plant, or it can come from a liquid oxygen. So if you look to the left of the screen and you look at the last two columns, you can get an oxygen plant, and then that can be piped to a wall system of oxygen, or you can have bulk liquid oxygen generated, and it can also be piped. So each of them have advantages and disadvantages, and it's very, and I've given you a link there, which helps us to understand about oxygen delivery, and this what is called the Oxygen Delivery Toolkit. So oxygen is not only the premise of the clinician, the doctors and the nurses, but it's the premise of the whole hospital system. So remember, we have to have a baseline assessment of how much oxygen can we have in a facility, and how many oxygen ports are there in a facility. We need to know how to quantify that oxygen. It needs to be procured based on how much we have and how much we can supply. There needs to be a distribution system of that oxygen where we need the biomedical team to come in. And then we need the management and training, both from the biomedical team and the clinical team. So you see, oxygen delivery is actually a life cycle. So everybody in the hospital system gets involved. There's the policymakers and the political commitment to the supply of oxygen. There is the financing part, which can be global and government also directed. And of course, it then comes down to even the facility. There is, of course, us monitoring how much oxygen we're using, monitoring levels when they go down, and how we are going to resupply these levels. So before we use it as clinicians, there's a whole team that needs to be involved in the supply of oxygen, the maintenance, and the distribution of the oxygen. So there's, again, I've given you a toolkit that we can all use in our various facilities to help us manage this oxygen delivery life cycle. So what is normal oxygen saturation? So I'll give you a case. There's a four-year-old female, a child, presents with cough, fast breathing. The oxygen saturation by a pulse oximeter reads 88%. The question to you is, does the child have hypoxia or hypoxemia? So hypoxia and hypoxemia are interchanged quite a bit. And so we'll go over what those mean. But your normal oxygen level at any one time should be more than 90% at any given time. So what's the difference between hypoxia and hypoxemia? So hypoxemia means there's low blood oxygen. So in the blood, the oxygen supply is low, it's insufficient. Usually lower than 90% for most patients. It can be even lower. Hypoxia is actually down the road, meaning it's not only in the blood, but in the tissue, there is low oxygen supply. So there's not sufficient oxygen for the normal life functions. Usually it will result because something has failed. So either the heart has failed, or the lungs, or the vessels have failed. The level at which this occurs, hypoxia, as in low supply of oxygen in the tissue, nobody really knows. So we all go by the low blood oxygen level, which is what we call hypoxemia. So hypoxemia leads to hypoxia, and then hypoxia leads to damage of our tissue if you are severely hypoxic. And of course, the most important organ would be your brain, and this can result in brain damage or actually brain death. So again, our 4-year-old female with a cough, breathing fast, the oxygen saturation by the pulse oximeter is 88. Does the child have hypoxia, or does the child have hypoxemia? Remember, hypoxia we're not able to quantify. So we are always talking about hypoxemia when we're talking about a saturation, an oxygen saturation. So hypoxemia is defined by an oxygen saturation, which we normally call an SpO2 of less than 90% for most patients. This can be less in patients who have chronic obstructive lung disease, and therefore most patients it's less than 90%, but in patients with chronic obstructive lung disease, it may be even 88%. So what are the causes of hypoxia? In children, it's pneumonia, bronchiolitis, it's asthma, any type of infection, including meningitis and sepsis, congenital heart disease, malaria, and trauma. In the adults, it's mainly pneumonia, asthma, chronic lung disease, especially chronic obstructive lung disease, heart failure, congestive heart failure, pulmonary embolism, and a lot of perioperative complications. So how do you recognize hypoxemia or hypoxia? So remember, hypoxia is very difficult to recognize, and so we go with hypoxemia, which is an oxygen saturation on a monitoring system. We have various monitoring systems, and you can see to the right of the screen, we have those which are attached to the wall in cardiac monitors. Then we have those which are more portable, and many of us at this point in time in the pandemic have them, and we have a slightly bigger but portable ones. So there's non-invasive monitoring where we use the SpO2 or the oxygen saturation. Either we are using portable oximeters or oximeters which are attached to a cardiac monitor. Then there's invasive monitoring, which is a blood gas analysis. Usually it's an arterial blood gas analysis when we're looking for oxygenation. And it's the most accurate test to check your oxygen saturation and also for diagnosing and of course hypoxemia. History and physical exam can also be used, but it's not as reliable as a monitoring system that is either the non-invasive or the invasive. So pulse oximetry, it basically calculates your SpO2 or your saturation of oxygen and can be used to diagnose hypoxemia. Some oximeters have an audible beep, which also can be used to estimate your heart rate. And sometimes it can help you decide whether the patient has a regular rhythm or a irregular rhythm, which might be the cause of the hypoxemia that the patient has at the time. So I hope this will play, but it's a video on how to do pulse oximetry. Can you see the screen?
Dr. Mugera, we can see part of the screen, but the video is not playing. So maybe what you can do when you finish is put this link on the chat so that people can also watch it after.
That's all right. Okay, fine. So the video basically shows you exactly how to perform proper pulse oximetry. And of course, pulse oximetry it can be inaccurate if you don't do the right things. So a good way to ensure that there is accuracy of the recording of your saturation is your pulse oximeter has to be connected correctly. So the patient should not be wearing nail polish. The extremities, if they're too cold, you might not get an accurate reading for that. If they're hypotensive or they're vasoconstricted for whatever reason, you may not get an accurate pulse oximeter reading. If they're pale or their HB is low, again, if they're anemic, you may not get an accurate pulse oximeter reading. And it's very useful because it helps you to visualize a regular pulse, and it should be taken for at least 30 seconds. So once you put a pulse oximeter, you must wait for at least 30 seconds before you give an accurate reading. So if you put it and it only reads 88, give it 30 seconds. If it still reads 88 at 30 seconds, and basically you can go on to another 30 seconds to 60. If it still reads 88 at 60 seconds, then the oxygen is low. Sometimes it fluctuates as it tries to read because depending on whether you're in an area with more light or less light, it can affect the pulse oximeter. So remember, no nail polish, ensure the extremities are warm. If they're hypotensive, you might get an inaccurate reading. If they're anemic, you might also get an inaccurate reading. But most importantly, keep the pulse oximeter on for at least 30 seconds. So I hope you can see this. This is another case. This is a 45-year-old male. He has HIV. He comes in with chills, cough, and weakness. His heart rate is 95 beats per minute. His blood pressure is 95 over 52 millimeters of mercury. His respiratory rate is 24. His SpO2 is 89 after 30 seconds, that is. And then temperature is 36.5. A few minutes later, his SpO2 goes to 83. What is your next step? Okay. So remember what I've just told you about inaccuracy of a reading. First of all, you have to have, if he's hypotensive, which our patient is, it may not be giving us an accurate reading. Okay. He's a male, so we don't think he has nail polish, or we hope not, at least. And the other thing is, if you look at the down of the screen, the picture to the left, notice there's a flow of his oxygen or his SpO2. And if you compare it to the one on the right of the screen, that waveform on the right of the screen is the kind of waveform you want to see, the second one from the top. That's the kind of waveform that you want to see to ascertain that you're getting a proper reading of your SpO2. The waveform on the left of the screen is not a good waveform, and that might be the reason why you're getting an inaccurate reading of his SpO2. So remember, those are a few things, tips and tricks that you need to look out for when you're taking your pulse oximeter reading. So what are the symptoms that you can use, especially when there is no pulse oximeter in your facility? So there are symptoms that you can use in adults. The early symptoms of hypoxia or hypoxemia is there's rapid breathing. There's difficulty in breathing. Usually they're short of breath. Many a times, as they're compensating, they get a very fast heart rate. They may have difficulty speaking in full sentences, and they may be coughing. Late signs include their inability to speak, and a lot of times their mouth breathing, wheezing, They may be sweating. They may be using accessory muscles that include muscles of the neck, abdominal muscles, intercostal muscles. They may be confused, and they may actually be in a coma. So clinical signs are not reliable predictors of hypoxemia, but when there's no pulse oximeter available, they are useful to determine whether your patient is hypoxemic. How about in children? So there's often nasal flaring, rapid breathing, inability to feed or to suckle. They may be drooling. They're usually lethargic. They may be irritable, and they may use intercostal muscles. Again, remember, these are helpful, especially when you do not have an oximeter. And remember, your physical exam and history are very important when you're wondering whether a patient is hypoxemic or hypoxic. So what do you do when now you find hypoxemia? The first question you must ask yourself is, how sick is this patient? So you should measure your vital signs and any other physiological parameters. So you need some equipment to measure your vital signs. You probably need a monitor, preferably a monitor defibrillator, so that you can do something about any unusual rhythm. You need a manual blood pressure device. You may need a non-invasive blood pressure device, which normally comes with most cardiac monitors. You need a pulse oximeter. You definitely need an oxygen source, whether it's from a cylinder, it's from a wall oxygen, whether it's from a concentrator. You need your IV administration kits, because they may need fluid. You need catheters and cannulas, and you must have oxygen delivery devices, including nasal prongs, simple masks, and high flow reservoir masks, which we normally call non-rebreather masks. The next thing you must ask yourself once you've taken all your vital signs is, does the patient need oxygen therapy? So there's a very good chart of how to use oxygen pulse oximetry for decision making. It's very busy, but I'll break it down for you. So as the case I had told you about this 45-year-old man with HIV, he's on heart. He's got 5-day history of chills, weakness, cough. He's got a heart rate of 95. He's hypotensive. His respiratory is 24, and his SpO2 is 89. So your question one is, does the patient have any of the following? So our patient had a cough, okay? He did not have a fever. His respiratory is above 22. He's an adult. Now, the other question you ask yourself, does he have emergency signs? Emergency signs include obstructed or absent breathing, respiratory distress, which is usually use of accessory muscles, central cyanosis, shock, coma, and convulsions. So our patient is hypotensive with a blood pressure of 95 over 52. We can't ascertain he's in shock until we give him a bolus of fluid and it does not respond. But it is definitely impending shock when his blood pressure is 95 over 52. So our patient has emergency signs, impending shock, he's coughing, and he has a respiratory rate more than 22. So what are we to do? If you look at the left of the screen, you check his oxygen saturation, which we know is 89. Does he have emergency signs? Yes, because he has impending shock. So the next thing to do is you provide supplemental oxygen. Usually you start with nasal prongs. Because our patient is at 89, you want to start with probably 4 to 5 liters, but you can even, and 1 to 2 in an adult. In children, you start at 1 to 2 liters. Then you titrate the rate to above an SpO2 above 90, then you can decide to go down or to go up. You don't leave your patient once you've put them on the oxygen. 15 minutes later, you must reassess and see whether your SpO2 is remaining the same, going up or going down. You must reassess and check for these emergency signs every 2 minutes. So remember, he had a blood pressure of 95 over 52. So we must repeat after about 3 minutes, repeat his blood pressure. If his SpO2 remains less than 90, and now we are on oxygen, and he still has those signs of shock, like the blood pressure being low, one, we can increase the flow of oxygen, okay? If, however, his oxygenation goes up from 89 to 90 or above 90, and now the shock has resolved, that his blood pressure after 3 minutes has gone up to 100/60, we should be happy. And then we continue to evaluate him and check his vital signs every 4 to 6 hours. We must always maintain our SpO2 about 90 to 96%, reducing where we need to or increasing. Our pregnant patients are special, and therefore we prefer to keep them at a saturation rate of between 92 to 96 rather than the lower 90. So if he continues to have the emergency signs of shock and we've increased our flow of oxygen, again, we reassess. If he remains to have his shock, again, now we move down to a critical care unit. So we must now engage the critical care unit and see how we can support his oxygenation or support his shock because he's not improving on oxygenation. If after increasing our flow of oxygen, his emergency signs disappear, again, now we can continue to do the vital signs every 4 to 6 hours, titrating our oxygen to keep the SpO2 between 90 to 96%. And of course, if it's a pregnant person, then 92 to 96%. So that's how we can use our oximetry to make decisions on what to do for our patients. So what are the indications for oxygen therapy? Cardiac arrest, and where we have to do the advanced cardiac life support, we need to use oxygen therapy and higher oxygen therapy. If the saturation is less than 90% by pulse oximetry, we need to use oxygen therapy. If there's respiratory distress, and usually we say a respiratory rate above 30 in adults, it varies in children. So for children aged between 5 and 15, so you look to the left of your screen, it would be more than 30. For younger children between 1 and 5, it will be more than 40. For infants, it will be more than 50, and if they're between 2 months and 11. And if they are neonates, then it is more than 60. And if there's any confusion or coma, that is an indication for oxygen therapy. So now you've diagnosed your hypoxemia, you know that you need to give oxygen to your patient. How do you deliver that oxygen? So there are various oxygen delivery devices. From the left of the screen, we have the nasal cannula, also called the nasal prongs. It normally gives oxygen between 1 to 5 liters per minute. And in FR2 or fraction of inspired oxygen, that's usually between 25% to 40% of oxygen. Then you can graduate to the simple face masks, and it gives a flow of 6 to 10 liters of oxygen. And that is a fraction of inspired oxygen of 40% to 60%. If the patient is still not improving, we can move up to what we call the non-rebreather mask, or the mask with the reservoir bag. And this dose is between 10 to 15 liters. You must, before you put on this mask on a patient, you must make sure that the reservoir is full. So because the patient breathes from the reservoir and not actually from the oxygen source that you're giving. So when you're using the nasal prongs and when you're using a simple face mask, you can put the prong and the mask onto the patient and then switch on your oxygen from its oxygen source, whether it's the wall oxygen or a cylinder. But when you're using a non-rebreather mask, you must fill the reservoir first with the oxygen before you put it on the patient, because the patient breathes from the reservoir bag and not from your source of oxygen. So do we know how to connect our devices from the source of oxygen? So you must know what your oxygen source is, okay? So to the left of the screen, there's a cylinder. It has a different type of adapter. To the right of the screen, which is also a cylinder. So you must know what your cylinder looks like. Does it need a key to be turned on, or does it just need a knob of a valve to be turned on? You must know what the regulator looks like and how to know whether there's actual flow of oxygen from your cylinder into your humidification device. You must know how to connect the tubings of the oxygen. Same to the middle picture, which is basically wall oxygen. You need to have the flow meter. You need to have an appropriate flow meter. You need to know how to connect the flow meter to the humidification device. So why do we don't normally give dry oxygen to patients unless we are giving them for a short duration of time. So if anyone requires more than 3 liters of oxygen and for a longer duration, usually more than 24 hours, their oxygen must be humidified. So if it's a short duration, a patient just walks in, you're not sure whether their hypoxia is from another cause or it's from because of their lungs being a problem, we usually put them on 1 to 2 liters of oxygen. If we determine that we'll need to be more than actually 4 hours on the oxygen, we need to add a humidification device. So once we've used our other delivery devices, there is also what we call the high flow nasal cannula oxygen therapy. And there's a link there to show you how the high flow nasal cannula therapy is used. And basically it is actually a gas blender as well as which is connected to a source of oxygen. And then it comes down to a level where it's heated and it's humidified before it goes into the oxygen tubing and then to the patient. So this delivers a higher flow of warmed and humidified oxygen, usually at a higher rate than your other devices. And it allows you to adjust your FR2 up to 100%. And finally, if you are unable to ventilate or rather oxygenate your patient with all the other devices, then the patient has to be ventilated with a ventilator. It can be invasive or it can be non-invasive. In the picture here, this is the type of invasive mechanical ventilation. So what are the goals of oxygen therapy? How much oxygen is enough? And what is the goal SpO2? So SpO2 of 93% or greater is considered normal. If you have a patient who has hypoxemia and you start oxygen on them, the aim is to deliver a saturation of about 90% or more. When they are pregnant, we use a higher goal, and that goal is 92 to 94%. So we'll answer our questions again. How much oxygen do we breathe in air? It's 20.9%, around 20%. So what is hypoxia? It's the decreased oxygen concentration in the tissue and not in the blood. What is hypoxemia? It's a decreased oxygen concentration in the blood. What's the most common non-invasive way to measure a patient's oxygenation? It's pulse oximetry. Oxygen delivery devices. So which one would you rank based on their FO2 delivery? So that's number one, the nasal probe. It gives you between 2 to 5 liters of oxygen. Then you have the simple face mask that gives you 6 to 10 liters of oxygen. Then you have the non-rebreather mask that gives you 10 to 15 liters of oxygen. So I hadn't talked about the fourth one. It's called a Venturi device. What a Venturi device does, it's a simple face mask, but then it's attached to those color-coded little devices. And what they do is they give a fixed percentage of oxygen, usually between 24 to 60%. So basically, using a simple face mask, which is to the left of your screen, where you are giving up to 10 liters of oxygen, you can give a higher flow if you connect this little color-coded gadget to the simple face mask and give much higher flow before you now then graduate to either mechanical ventilation or high flow nasal cannula oxygen. So what should we be doing in our institutions? First of all, we must find out what is the oxygen supply that we have available to us. Is it an oxygen plant? Is it liquid oxygen? Do we have cylinders? Once we know what we have as the oxygen source, we must know the number of the oxygen source devices that are available, whether they are cylinders, concentrators, or if it's a liquid oxygen supply, we need to know the volume of that supply. And so we should be able to know what is the reorder level of that supply. We need to know who maintains the oxygen supply system. We also need to know the oxygen delivery devices that are available to us and how we can use them in their various conditions. We also need to understand who orders the oxygen, who maintains the oxygen, who also orders the oxygen delivery devices, who maintains oxygen delivery devices. Are they disposable or reusable? And if they're reusable, how do we sterilize them? Do we sterilize them in chlorine or some other agent, or do we autoclave them? And then we also need to we have to have the oxygen delivery toolkit guide, which helps us to know and involves everybody, the biomed, the procurement, the finance people, about oxygen delivery. So all of us must work as a team, clinical and non-clinical, to be able to improve oxygen therapy and oxygen delivery. Thank you.
Thank you so much, Dr. Mugera, for an excellent talk. I think all of us sitting here are glad we joined this. So maybe just a few questions before we move on. So someone is asking, what is medical air and what is it used for?
So medical air basically is used to sometimes, okay, for the old ventilators, we blended oxygen with medical air. So medical air, I forget the components of the medical air, and maybe Dr. Adempesa can help me with that. But it's used, it can be used for surgical devices, the ones that are run by pneumatic systems, and some ventilators use it. That's what it's mainly used for. But Dr. Adempesa, maybe you can help.
Hello, can you hear me?
Yes, we can hear you, Doc.
Oh, okay. Yeah, so medical air has various uses in a hospital setting. One is if you don't want to give 100% oxygen, let's say for a patient who is intubated, and then, so the way you titrate down, let's say to 90%, 70%, 50%, what accounts for the remaining percentage for you to give that 60% or 80% is basically medical air. And then, as Dr. Mugera has said, it is also used to run certain equipment. So if you look at most of the ventilators, they have something called a compressor. So in the event that there is a power loss or anything like that, then the ventilator is usually powered by a battery, and you can use medical air actually to run the ventilator. Yeah, so that is one of the indications. And then in other areas of the hospital, like in theater, like pneumatic drills, they are basically run by medical air.
Okay. Thank you so much, Dr. Adempesa. There are a few other questions that have been asked that I'll ask Dr. Mugera to answer, but remember, we'll be going through this series for the next 4 weeks, so some of this will be covered again. So one of the questions, Dr. Mugera, is sometimes people say if someone is not oxygenating well on a non-rebreather mask, put a nasal cannula, then put the non-rebreather mask on top. Is it of any value in terms of increasing the fraction of oxygen that is delivered?
So technically, I suppose, so the question is, you have a nasal cannula, and then you add mask. Is that correct? Have I understood the question correctly?
Yes, sometimes the assumption is that if someone is on a non-rebreather mask on 15 liters and you're not getting oxygen, you add a nasal cannula 5 liters. Are we actually delivering 20 liters of oxygen in that case? Is it a practice that should be encouraged? Yes.
So ideally, you should be moving from a lower delivery device to a higher delivery device. So from a non-rebreather mask, which gives you about 15 liters of oxygen, what you should be moving to is either a high flow oxygen device that gives you higher concentration of oxygen, or to a type of and a mechanical type of ventilation. In theory, it makes sense that you may be delivering more, but I don't think that is accurate. That's not an accurate assumption. So we should actually be progressing. So if you have nothing else, it should be helpful, but ideally you should be now looking for how to refer this person to a facility that can offer more oxygen to your patient.
All right, thank you so much. And in one of the future sessions, we'll be looking at how to safely refer patients who are on oxygen. So the other question is, you mentioned oxygen concentrators. Maybe just a thought of when should they be used? How should they be used? What is their role in the hospital setting?
So oxygen concentrators are of two types. They are of types that give you up to from about 1 to 5 liters of oxygen. And then there are others that give you from 5 liters to 10 liters of oxygen. So if you, for example, are using cylinders and your cylinders run out, you can also use an oxygen concentrator. But you must know, number one, what is that? How much flow can that oxygen concentrator give me? It's not that it will give you more than your wall oxygen or your cylinder oxygen. And you must know whether it's one that gives you between 1 to 5 liters, or is it one that gives you between 5 to 10 liters. So I don't know of concentrators that use more than 10 liters of oxygen. So if your patient needs more than 10 liters of oxygen, then they may not benefit from an oxygen concentrator. The advantage of an oxygen concentrator is that it extracts oxygen from the air, okay? So it's cheaper in the long run. You're not having to buy or refill a cylinder. So it can be useful in a facility, especially like in dispensary settings. I think an oxygen concentrator is a good one to have. Places, the only downside of the oxygen concentrators, most of them are actually run by electricity. So you'll need a good supply of electricity or a backup for your electricity supply.
Thank you so much. And someone is asking a very practical question. For cylinders, some people may have had cylinders in the facility for a long time. It's never been used. How long do you keep a cylinder? How do you check that the oxygen is still there, is still okay? If you've used part of it for a patient, how do you know whether to keep it? And if you keep it, is it still there? How do they monitor that resource?
That's a very, very good question. And that's why I say the oxygen delivery is not just for the clinician. It's including your other allied medical staff, including your biomedical staff. I will have to ask Adebesa about expiry of oxygen. I don't know when it expires in a cylinder. However, I know you can use one cylinder on more than one patient. So if you've used with one, so long as you can read your flow meter correctly and you can read your gadget, and maybe I'll go to that slide. 1 second.
Oh, sorry.
So you can see all these monitors on if you look to the right of the screen, there's the gadget that is attached to the tank itself. Then there's a flow control valve there. There's the flow rate. So all these are useful in telling you how much oxygen remains and whether you can reuse it or not in terms of how much oxygen remains. And we must all be trained on how to even switch on the oxygen so that we know it's flowing and coming to our cannula tubing. maybe Atembesa can help me with the one of how long does it last? I don't know. I really don't know the expiry of oxygen.
To be honest, I don't know. I don't know. I can't comment on expiry of oxygen. Yeah.
So
Okay.
I am definitely the biomedical people will be the ones to assist us with that.
Okay, thank you very much. We'll try and reach out to biomedical and see if we can have a response at the next meeting. So one question was, is there a difference between medical oxygen and industrial oxygen? There's a time we had some industry saying we can offer, people can bring their cylinders, we fill for them oxygen. Is there a difference? Should people take that up and rush there with their cylinders, or should they not do that?
So oxygen, medical oxygen is about 82% pure oxygen. Unfortunately, I don't know what percentage of oxygen industrial oxygen comes by. So maybe the other panelists might be able to help me. So, and then of course, it's pure oxygen from any other impurities as compared to even air. So one would need to know the composition of that industrial oxygen for us to say, yes, it's safe to be used by any one of us. That's something I can find out.
Oh, I know Dr. Mugera will be joining us again in the course of the next few weeks. So maybe some of these areas we can also try and get answers before then. So thank you very much, Dr. Mugera. That was such a good talk. We're really, really grateful that we got the opportunity to listen to you. As I said before, we'll be going on with this. Sorry, Dr. Chokwe, Professor Chokwe has indicated here that oxygen shelf life is 3 years. So if there's a dusty cylinder in the corner that's been there for 10 years, you need to get biomed to look at it. Okay, so I'm going to stop this one here. Next week, we will have 2 people, one chest physician and critical care specialist. So Dr. Munyu Aweru and Dr. Ruben Okioma, who will be talking about the other aspects of oxygen, how to deliver to a patient, how to monitor a patient while they're on oxygen, issues around a safe referral and transport of patients who are on oxygen. So I know there's some questions that I've sort of tied to that. We will follow that up next week. And then the next week, we'll again have more on the oxygen training. So thank you very much, Dr. Mugera. Let's all clap for Dr. Mugera for such an excellent talk. Thank you, Dr. Mugera. We really appreciate you for coming today, and we're looking forward to the next time you're joining us, which will be week after next. So again, as I said earlier, we're going to have this series going on, so please keep joining for the next few weeks. We also have today with us some of the people from the facilities who will be sharing with us some of the experiences, including how they're using oxygen and some of the challenges that they have. And first, it's my pleasure to invite Dr. Adembesa. Dr. Adembesa is an anesthesiologist and critical care specialist at KU-TRRH. Dr. Adembesa, you can go ahead. Dr. Adembesa, you can unmute and share your screen.
Can you hear me?
Yes, we can hear you now.
Are you able to see my screen?
Not yet.
Okay, let me just try.
Okay.
Are you able to see it now?
Yes, 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 we can see your screen.
Okay. Thank you so much for inviting me for this webinar. I'll do a very short presentation basically on our experience at KU Hospital And I'll concentrate basically on how we manage these patients in our critical care units. So as you're all aware, Kenyatta University Hospital has been at the forefront in managing of COVID-19 patients, especially here in Nairobi. The hospital is basically a 650-bed public hospital. But over the past 1 year plus, we've been able to increase our ICU capacities as the disease progresses, as well as opening up other departments in the hospital. So as of today, we currently have we've divided the ICU basically into 3. So we have a 40-bed ICU dedicated to COVID-19 patients. And then we also had to create what we call a suspect ICU stroke HDU, because you're getting a lot of referrals, especially from the counties. And some of these patients come in when they don't have a COVID test. So we don't know whether to put them in the COVID unit or non-COVID. And then, of course, because the other departments in the hospital are also running, we currently have a 25-bed non-COVID ICU to take care of the other patients. We also have an oxygen plant, which has been very useful. Although I remember at the peak of the 3rd wave, we were experiencing strain to the point that at a certain point, instead of giving 100% oxygen, you realize your ventilator is only giving about 90%. And this was because of the huge number of patients who are in the hospital and who required oxygen. In terms of our non-COVID ICU, for those who've managed these patients, about 20% of all patients who come to ICU need renal replacement therapy. So we had to make some adjustments to our ICU, and we have 3 dialysis spots. And in addition to that, we also have 3 CRRT machines for those patients who are hemodynamically unstable and they can't tolerate normal dialysis. Our ICU is also equipped with a negative pressure ventilation at the rate of 6 to 12 air changes per hour. We have a clearly demarcated donning and doffing area, and there is a launch for staff when they are resting and when they are not attending to the patient. But in addition to that, because the most important thing in managing COVID-19 patients in ICU is monitoring, we've also have CCTV cameras installed in our unit and a central monitor in the clean area. So this is just a picture of how a part of our ICU looks like. You can clearly see the big screen with CCTV camera, and we're able to see all the beds in the unit. And then there's also a central monitor, as I had said, which is domiciled in the clean area. For our standard of care, we are able to do all these tests, starting with the gold standard for diagnosing COVID-19 is a PCR test. But there are some instances, especially for surgical emergencies, where we have to do rapid antigen tests just to have an idea of the status of the patient, especially if the patient needs ICU. And then we do the rest of those tests as listed as need be. But the most important test to me for managing these patients in ICU is a blood gas analysis, because as Dr. Mugera had mentioned, the only way you know how much oxygen you're giving to this patient is if you are able to monitor the partial pressure of oxygen in the blood. In terms of management, at the beginning of the pandemic, we were all giving these patients multivitamins. We went on to start giving remdesivir, ivermectin. But as evidence comes out, for now, currently, our standard therapy, all our patients are on dexamethasone. And this is based on the evidence, especially that came out from the recovery trial. Again, as new evidence continues to come by, you'll see in my next slide, we've realized that there are those patients, despite being on dexamethasone 6 milligrams once a day, they continue to deteriorate. So what do you do in that case? So we've seen very good outcomes with pulsing these patients with very high doses of dexamethasone. And some of this evidence we got from some of our colleagues from the UK, and we've adopted that as part of our protocol. You know how precious tocilizumab is in this hospital. So there are those specific patients who meet the criteria, especially those with severe disease and they have elevated inflammatory markers. Then we consider them for tocilizumab. The only drawback to it is the cost. It's very expensive and not readily available at times. And then, of course, thromboprophylaxis is very important. Evidence on use of various forms of multivits is not yet there. So for us, we don't give it routinely. Glucose control is very important. One, because a number of the patients who end up with severe COVID disease are diabetics, but we've seen a lot of patients who are initially were not diabetic, but then come in with the DKA or new onset diabetes because of COVID-19. And then, of course, when you're using high doses of steroids, it also comes with with challenges with glucose control. Again, antibiotics, I know it is something that as a country, everyone was getting azithromycin at the beginning of the pandemic. But again, the evidence that has come out, there is no role for antibiotics, just like in any viral infection. So we are only considering it for patients who have superimposed bacterial infection. Then, of course, you have to treat the other comorbid. Now, this is the slides I was talking about, the role of steroids in COVID-19. There are those patients who have severe critical disease, they've been on steroid movement. So we adopted this. This is from the King's College in London. And what we usually do nowadays, any of our ICU patients who are severe disease, they've been on steroids, they're not improving, the inflammatory markers are still going up, we pulse them with very high doses of steroids. So in our case, we commonly use dexamethasone. We give them 20 milligrams once a day for 5 days, and then start tapering off. So you give 20 milligrams once a day for 5 days, then 10 milligrams for 5 days. Then you keep tapering as shown in that chart. And we've seen a lot of the patients that are on NIV, when you do this, use these regimes, very few end up requiring intubation. And we all know what happens when you intubate this patient. So as after we started adopting this, we have very, very few patients in our ICU who are actually intubated. And then, of course, preferably consider take orally by themselves. A lot of these patients, you've noticed, get ICU delirium, and they need psychological support as well as treatment of ICU delirium as well. And then fluid therapy is still a big challenge, even to us. How much fluids do you give without compromising your oxygenation? And not under giving so that you don't push the patient into pre-renal failure. So this is still a huge discussion, and nobody really knows how much is enough. But my answer to this is, I think individualizing for each patient is very, very important. Then, of course, renal replacement therapy, both from regular hemodialysis to SLED to CRRT is very important. I decided to share this table. You remember at the beginning again of the pandemic, these were guidelines from China last year. There was emphasis on early intubation, but as we've all seen along the way, most of these patients don't do well if you intubate them early. So for us, our first choice is non-invasive ventilation or high flow nasal cannula. And we only consider intubating these patients if they have failed NIV or high flow nasal cannula. And then that is the only time we intubate, and we follow the ARDS guidelines, which is, use low tidal volumes, titrate your PEEP, check on your peak airway pressures. That is a whole lot of another discussion, and then prone positioning also helps. We are not at the level of doing ECMO, but in other centers around the world, they consider ECMO in those patients who, despite being intubated on mechanical ventilation on maximum support, they still deteriorate, then ECMO becomes an option. This is one of the studies we did in our unit, as just to emphasize the importance of NIV. So when you inject these patients on NIV early enough, it reduces the work of breathing, improves oxygenation, with very minimal changes in your partial pressure of CO2. Now, at Kenyatta University Hospital, we had our first patients in April last year. We've had a total of almost 750 patients with severe COVID-19 going through our ICUs. Our mortality is about 36%, which is in keeping with the rest of the world. There was this meta-analysis early this year. As you can see, in hospitals across Asia, Europe, and North America, the average mortality is between 34 to 49%. So I think we are doing better. We are doing well, and we can do better. Coming closer home, this is a recent study published in the Lancet by the African COVID-19 Critical Care Outcome Study, which was run by a team from South Africa. And from this study, they found the average mortality for ICU admitted.
Please progress the slide. Sorry, we're still seeing the previous slide.
Are you seeing this?
Yes. We are seeing the one on oxygen. Okay, it's okay. Go ahead.
Is it progressing now?
No, it's still stuck on the one on oxygen.
I don't know what's happening because on my side it's saying it's sharing and I'm able to move the slides.
It's okay, just go on.
Yeah, so coming closer home, there's a recent publication in the Lancet, African COVID-19 Critical Care Outcome Studies, and it basically looked at patients with COVID-19 who are admitted in critical units across 27 countries in Africa, and the mortality they found was 48.2%. So finally, in terms of challenges, we are a new hospital, and as we all know, it takes time to put systems and policies into place. So this has been a huge challenge. Staffing is still an issue, considering the number of ICU beds we have. It needs a lot of staff, and it is something we are working on with management, but they've been very supportive. Stockouts, both of drugs and non-farms. Sometimes we run out of some drugs, but again, management has been supportive, but it's something that we can do better. And then, of course, majority of our patients are referred from other facilities. We've had instances where a patient is transferred from a facility far away from Nairobi, and along the way, the ambulance runs out of oxygen. By the time they get to a place, you start by resuscitating the patient. So this, Dr. Lois is running a series on oxygen therapy. I hope we'll have a session on how to transport some of these patients with severe COVID-19. Thank you so much.
Thank you very much, Dr. Dembesa, for an excellent talk. I think the work you have done, even just the sheer volume of patients that you manage in ICU, is astounding, and we salute you and your team. I think just one of the comments I wanted to make, there's one slide you shared around the use of steroids, and there was an option on high-dose steroids. So we've sort of tried to discuss this severally in the webinar and try to review as much as possible the evidence around high-dose steroids. And I think just for the listeners is that at this point, we do not have a lot to support high-dose steroids, and many of the series that have been published suggest that there may be slightly worse outcomes. So it's something that should only be done with specialist consultation and support. So thank you very much, Dr. Dembesa. We know you had to stop on the way to join the webinar, and we really appreciate your time. So now allow me to invite Dr. Mohammed Sood from Coast General. Dr. Sood is our regular. Thank you, Dr. Sood, for joining us again.
Thank you very much, Lois, for that. This morning, we're just going to go through the current situation. We have 48 patients and 8 in critical care ICU on NIV. And we have males 21 and female 27. We have 13 suspected cases, and in home base, we have almost 30 of them at home. Now, this is our current situation, which is happening now. You can see the wave actually started by around 3rd July. We have a very sharp rise in terms of the number of cases. And around 10th, you can see actually the numbers went really high. Now, sometimes you get these blips where they are 0, but if you look at it, these are on weekends. And because we also lack kits, a lot of our tests tend to go to Cambry for testing. So there are delay in results. But then you can see when it comes to Monday or Tuesday, the numbers again usually move up. So our percentage of positivity average is around 13.7. And if you look at through the months, you will see it's only around May when we were actually moving lower down. And then from June, we have actually been climbing up in terms of our positivity rate. Now, the pictures we see have not changed much, but the progression has changed. Now, there are some patients we have done these CT scans on day 1, and then we repeat them on day 3. And you will not believe the change which really occurs. The severity scores move up by almost 10. Some of them, we have one of our colleagues, a healthcare worker, on day 0, the severity was 0/25, and then started developing breathlessness at day 2. On repeating the scan, it had moved to 13/25 within just 48 hours. So this is why we are advocating people to come out early, because we have seen the change in this wave is actually different from the ones we have seen. Of course, we have some of the challenges, we have some problems which we offer solutions and see. I will just touch with you based on what challenges we are facing and what solutions we have tried to put in. The first one usually is the human resource. And of course, you can bring in human resource, but as the numbers increase, you need more specialties, especially in the nursing area where you need critical care nursing. So what we have done to counteract that, we have been running training programs for critical care COVID, so that we can have more people to understand how to take this critical care approach in all the patients. And we have had almost 2 trainings on this, and also we are doing continuous training every week, also on home-based care. Now, of course, there are so many hospitals which have closed down their centers, so we get a lot of referrals also to our facilities. And in the last month, we managed to get around 33 patients referred to our facility. This month, we are just on 16th, but we already have around 15 patients referred to our facilities. Of course, there is also fatigue in terms of protocol adherence and people not following anymore the hand washing, masks. Some of the things we face is the test kits are not available, and the samples have to be taken to Cambry, and it involves a lot of time to get to know the diagnosis for these patients. Now, of course, a lot of hospitals now have moved into rapid antigen testing, and some patients go to CT scan. But once they do this, the antigen tests, you find these people just disappear, and we never see them again. Some of them, even after doing the CT scan and being told their features suggestive of COVID, they disappear. And the time you see them is when the saturations are 50, appearing at the tent, and mortality is inevitable at that time. Now, I don't know if we can have policies where, fine, you can do the antigen testing, but if you get the antigen positive, can you highlight or contact the public health county office, which can actually follow up on these results so that we can do a PCR on them? Or if it is a CT scan which is suggestive, can we have the reports coming through public county, and then we can follow up on these patients who have a CT scan which is suggestive. I mean, if we miss the contact tracing in this condition, then we are going to lose this battle at any point. Patient come in severely sick. This is also true for home-based care monitoring. In the county, what we came with is we had a meeting and decided that we have a list of registration of people who have trained for home-based care, and each group must have a consultant in charge of that home-based care so that we can have troubleshooting and not a patient deteriorating at home up to a level that they cannot have any more hope. That is when now they are coming to the facility and the mortality remains the same. But if there is supervision in home-based care, then we tend to do better. So we have sat down with our chief medical officer, and even today we are having a meeting. We have set down the registry of all those who we have trained in home-based care, and we are trying to partner with also the private facilities to see when they send patients home, who is in charge of those patients, and if they complicate, what is the procedure for referring them. So these are some of the challenges which are coming up. Of course, I've always put NHIF there, and it is unfortunate that this is year 2. We are managing our patients, but we are not covered ourselves in case of any mishap. Then we don't have any insurance to take care of ourselves. So with that, Lois, I want to say thank you for these webinars, and I usually appreciate when I join. Thank you very much.
Many thanks, Dr. Sood. I think there's so many lessons that we can learn from you, especially around just home care and around testing. And I noticed someone asked a question like, a rapid antigen testing. Are you doing more rapid antigen testing? Would that be the reason why? Are you offering a lot more testing? Are you picking more people? What would account for this increase in positivity?
Yeah, so in terms of availability and also the cost of rapid tests is cheaper, because a rapid test, usually the kit is around 800 shillings. So even if a facility charges 1,000, then you are better off to go for a rapid antigen test than do a PCR, which will cost you 7,500. And currently you can see we don't have kits. So if you come to our government facility, we cannot offer that service because we only reserve it for the patients who are actually sick in the hospital. So most of the people tend to shy off and go towards that direction. And a lot of them go for CT scan for one reason or another. When you do a CT scan, then you can slowly disappear in the woods and no one will follow you up because there is no highlight of your name appearing anywhere that you have suspected COVID. So stigmatization still plays a role in this part.
Thank you so much, Dr. Sood. I think maybe Samira asked about whether antigen tests contribute to the positivity. Antigen tests may contribute to you being able to test more people, but it shouldn't increase the positivity rate. So if there's an increase in positivity rate, it's probably a true reflection of what's happening in the community. And yes, there are several MOH approved antigen tests. You can get in touch with the National Public Health Labs for any further advice. So allow me to invite Dr. Neto. Dr. Neto is a clinical pharmacist from Joe TRH. Dr. Neto, karibu.
Yes, good morning.
Good morning.
Okay, so I'm Neto from Joe TRH. I'll be doing a presentation on the update up to where we are at. So I'll start with the statistics at Kisumu County. Relatively, we have had around 8,500 cases. This data as of last week. Active cases currently, we have 321. Within the facility, we have 52. And those who are in the home-based care, around 269. Mortality so far are at 248 within the county. This just shows the trend of the numbers, and as it is right currently, we are seeing less and less numbers being reported in the county. This is the trend of weekly positivity rate all the way from the beginning of the year. And currently, as of last week, we were at 9.1%. So clearly, there's a downward trend in terms of the numbers. This is our critical center at Jaramogi, where we take care of the critical cases. It was the initial COVID-19 center where we initially taking care of our cases, but currently our bigger site is on the other side. We call it the Kondele site, where we have 98 beds. So this is one of the nursing stations, and within both units we have CCTV cameras connected at where the nurses can be viewing the patients from time to time. Now this is just the capacity as I've presented. Now within DRH, cumulatively we have admitted 648 patients, and we have lost about 234 patients. This just shows the trend of admissions from last year. You can see during the first wave, we had about the peak at about 24 cases. The second one in November, we had 45 cases. But again, this year, we can see we had around 240 cases just last month alone, with a very huge surge, which was even more than the totals that we had last year. Now, in terms of mortalities, again, also similar was observed, and clearly we are actually on the falling phase of the current wave. The numbers that we are seeing here are also of yesterday, in the month of July, where we are in. We have admitted so far 41 cases. Now, this is just a pattern of admissions for males and females, as well as their various age groups. We are seeing more and more of in the older people being admitted in our isolation. But again, for the younger age group, it's more of females, being admitted compared to males. This just shows the weak trend from the beginning of the year to currently where we are in terms of admissions and mortalities. So what we are seeing is less and less numbers. Now, in terms of mortalities, so far, the numbers we have lost, mostly the elderly people of the population, but again, among the young people, we have fewer and fewer people, dying. But again, also uniquely, we noticed in this age group of between 31 and 40, there's that tendency of losing more females than males. But again, in the other age groups, there's that pattern of males mainly. Vaccination so far, we have vaccinated around 34,000 individuals who have received the first dose, and second dose around a third of those who had received the first dose. Of course, there have been challenges of vaccine supplies, but currently we received the last batch which was supplied this week, and the vaccination has actually resumed. So we are working with the hope that we'll have more and more people being vaccinated in our setting. Currently, in fact, when the last batch was supplied, we saw a very good response in terms of clients standing up for the vaccine, and especially the older people in the population, as opposed to initially where we had a lot of outreach going out to reach out to many people to be vaccinated. Now, challenges still cuts across. Late presentation has been our major challenge, where patients are coming in late, quite advanced. Actually, it's one of the leading causes of mortalities. Testing also, we still don't have that capacity to test as much as possible, but as it is right now, we have a lot of support from the national government and KEMRI to help us to do testing. We're able to do PCR and RDTs within the facility, and the bulk still goes to KEMRI. Something else also on, in terms of resources, financial allocation for case management. What we had been given last year, somehow we are running low on that, and we're working with the hope that we may get more funds, because currently most of our patients are not being charged. But again, just in case we run out of those resources which were given earlier, it may become a challenge to continue managing these patients without charging them. So we're working with the hope that probably the national government will disperse more funds in this regard. Now on oxygen use, so this month we have the subject of oxygen. At Jaramogi, we have a flask where we are keeping liquid oxygen with a capacity of about 6,000 kgs. And also we have cylinders as well. And there's a plant being installed of 500 liters per minute. It had just been connected to the main line to at least supplement the liquid oxygen. For oxygen delivery, as had been mentioned, we have the various delivery systems, the nasal prongs, simple face mask, narrowbreather masks. We also have the high flow nasal cannula, as well as the ventilators, where we use the non-invasive ventilation. Some of the challenges we have with oxygen use, whenever we are stepping up, sometimes we face those limitations, because as it is right now, we have only 5 high flow nasal cannula, the ones that can deliver oxygen between 30 to 60 liters per minute, which as it is right now, we are also working with the county government to get more. For the ventilators as well, also there's that limitation as well, and we are working on acquiring more of these equipment. Again, also with whenever we have large numbers, as last month when we had the surge, sometimes the FiO2 tend to reduce up to around 90%, but again with the liquid oxygen it's normally 100%. So at times it reduces, and the biomeds have been quite helpful in that regard in adjusting the pressures. Medical, the various devices and the supplies have been a challenge from time to time, and especially the nasal cannulas for the high flows. So again, from what we have learned previously, we need to prepare ourselves better for the fourth wave. I think I've mentioned most of this. Currently, we are planning to expand the isolation bed capacity ahead of the fourth wave, just in case it comes, by increasing more oxygen points in the medical wards. Also, the installation of the oxygen plant is ongoing. Also working on the improving the facility, testing. PPEs also has been a challenge in the past, but there's a procurement plan in that regard. Trainings, we have realized that sometimes when we have a surge, we recruit more staff to come to assist, but again we realize there's always that gap in training. So there's that continuous training that we are doing. With regards to public health measures, a lot of community sensitization is ongoing, and especially last month when the Lake Basin region economic block was zoned out, we've had a lot of activities ongoing, like inspections that have really been useful in reducing the positivity rate in these areas. Otherwise, these are the partners that have supported us so far in this current pandemic. Otherwise, thank you very much. Back to you, Lois.
Dr. Neto, for that presentation. I just wonder, how much testing are you doing? And are there patients who come with symptoms who end up not being tested?
Well, currently we have the RDT. There are these devices which we go, the Lumira, which can at least give us results after around 12 minutes. We normally do the RDT. Just in case it tests negative, then we have our patients at the holding area are waiting for the PCR. That is if they are still symptomatic. But if they test positive, we take them to the isolation. So we have at least the tests being done within the facility for those who present with symptoms.
All right, thank you very much. Now you have experience managing large number of patients. I hope you're communicating to the community really well so that you don't experience another surge. But thank you very much for the work that you're doing. I'll ask for your indulgence. We have one other speaker, Dr. Wagude from Siaya. He has a short presentation. If we'd kindly just give him the opportunity before we finish. Dr. Wagude, my classmate, my friend, karibu.
Thank you, Lois, and good afternoon. Emphasizing the afternoon part, I think.
Good afternoon.
Lois, you're buttering me up
Good
because you know
afternoon.
time is over. So let me try to rush because you've said it's a short presentation. Thank you for the welcome and take you through what's been happening in Siaya County. Can you see my slides? Can you see my slides?
Yes, we can. Sorry, I was on
Okay.
mute. Yes, we can.
Okay. So let's see, the first case was reported last year. And in Siaya, we have about 310 beds for isolation with 60 with oxygen supply, 3 ICU critical care beds, and we have a plant in the county. Our total cumulative cases so far are 2,918. And right now we have about 16 cases in the facility and 239 at home. In terms of healthcare infections, we have about 142 who have been infected, and we have about 92 mortalities. Sorry for that, it's not 0.2. And a case fatality rate of about 3.2%. The cluster of cases in those following areas have now been reported in all of them. Remember earlier last year it wasn't, but all these areas have been affected now, except for refugee camps, which we don't have. And this is our epic curve. We had the first wave around July last year, then the second wave, November, December. Then we're still in our third wave, but the numbers, as you see, are beginning to slide down. And that's just the trend by age and sex. And highest number is in the productive age group, 20 to 40. So in cases of follow-up, we have 239 home-based care. We discharged 2 patients, that's brought it down to 12 in the hospital. We have a child of 6 years and the oldest patient is 83. 4 on oxygen and 2 are on non-invasive ventilation with helmet. And of course, there are comorbidities, and one has just came in having lost her pregnancy, early pregnancy. In terms of lab testing, there are about 190 tests in the last 24 hours, with 21,000 tests done overall. 23 cases were reported, that was as of yesterday, with the total positives of 2,918, and an estimated positivity of 12.1% in the last 12 hours, that was of yesterday. So we are using test kits right now. We have rapid tests, that's the PanBio Abbott and the biosensor. We also send cases to Cambridge, both from research programs and for the ones who are suspicious, they're still negative on rapid, but they're hypoxemic. We have stocked out our GeneXpert and Luminax RDTs, though we utilized them all before they expired. Turnaround time right now for testing is 30 minutes on average, except for PCR, which we get after 6 hours. So we are trying to decentralize the RDTs to each sub-county hospital, and we really need to hire more lab staff to reduce staff burnout with the testing that we're doing right now. So in terms of sequencing, last month we did a sequencing of the COVID tests that we had, and we detected that the Delta variant, otherwise known as the variant formerly which was formerly first detected in India, was about 89%, and the Alpha variant, that's the variant which was first detected in the UK, is about 11%. So you can see most of our patients are presented with the Delta variant strain. In terms of mortality in the hospital, we have lost about 82 patients with a case fatality overall in the county of 3.2%. And community mortality, those are the patients who are at home, about 10. There is now clustering of mortality in specific counts, like in Bondo and Alego. There are villages which have reported several deaths. And these are usually around when the people attended church together or attended a funeral. For those who died in hospital, those are the statistics. Usually the range is 29 to 92 years, and a lot of them have comorbidities, as I've shown you there. And that's the mortality trend. And you can see we didn't lose a lot of patients in the first and second wave, but when we came to this Delta strain-driven wave, we actually have had a lot of mortalities in the last 1 and 2 months. And in that same period, this is the highest time we've had our highest number of healthcare infections in the last 2 months. Luckily, we have not lost any healthcare worker to COVID yet in Siaya, which we are so far happy to maintain. In adherence to COVID-19 preventions, I think it's the same as for what I saw for Dr. Sud. Hand hygiene is not done much anymore. PEPs, we have PPE still, especially in the isolation unit, but face mask use has fallen drastically. I think people have gotten tired, and there's business as normal in most matatus and bars. And this is complicated by attendance of funerals and a lot of COVID denial despite the deaths. I think you know about the mass gatherings we had before these current outbreaks that contributed to the current outbreak we are having. And we still don't have a lot of enforcement of COVID rules in funerals and mass and political gatherings. That's the update for vaccination. I won't go into that in a lot of details. If you come to the hospital, that's the trend of our admissions. We had our highest ever number of admissions, approaching 53 in the last month, as well as the highest number of mortalities in the same period. That's the 200-bed facility we have, which we built we completed around October, November. We have about 40 oxygen outlet ports in the 200 beds, and we created an HDU section with 3 ventilators, which with monitors and non-invasive ventilation, and we can also intubate. But there are reasons we refer those patients for lack of some equipment, especially blood gases. In this third wave, like I said, we had our highest admission of inpatients. Our options of COVID management, we can give supplemental oxygen from prongs, non-rebreather masks to non-invasive ventilation. We also use IV dexamethasone, and on occasion we've had to sometimes use a pulse when we felt we needed to. We give prophylaxis, only use antibiotics when indicated, especially with evidence of bacterial infections or sepsis. One of the big challenges is glycemic and blood pressure control, and we also give supportive management, and we're able to do some tests, but we're limited in quite a number of tests that we can't do. We're only able to provide hemogram, renal function tests, sugar, and LFTs. In terms of the oxygen use, as Dr. Alois mentioned, we have an oxygen plant which gives us 4.5 liters per day. And initially, we were supplying other Lake Region counties during the third wave, but our own facility exceeded the capacity of the plant. As you can see, even this month, we are still on occasion, had days where we really needed as many cylinders as possible in the isolation. So the plant has had to cut supply to other counties and other facilities because of the recent admission in our hospital. So briefly, in end, what are the lessons we've learned in terms of this Delta variant and the third wave? We've seen increased community transmission. So in our hospital, we are testing all admissions and getting quite a number of patients turning positive, even when they are coming in with other indications like for delivery and surgery. We've had a lot of referral cases from outside our county and within our county who present late, and these ones usually have increased mortality. And we've seen increased need for oxygen delivery, and sometimes we have had to refer to Kisumu for high flow oxygen, which we are not able to give. The home-based care system, as Dr. Sud had mentioned, had broken down. With the high numbers of patients who are at home, there was hardly any clinical monitoring of patients. So a lot of patients either got worse at home and came very late, or some succumbed at home. I've also had a lot of issues managing hyperglycemia. So insulin has been very important, but we've managed to get control of most of these patients who get this due to the dexamethasone we're giving. The hospital has also suffered financial constraints, as Dr. Neto had mentioned, because we're giving free treatment and not getting a lot of funds to support what we're doing. Healthcare workers, even in the isolation unit, got infected. So we're trying to rotate staff through the isolation unit. We are trying to make sure everyone is vaccinated, and we are testing as frequently as possible, especially for those working in isolation. We also know that we've seen that we've come close to overwhelming our hospital capacity in terms of oxygen and supplies, and this is a warning to all the other counties. If you get Delta, you have to prepare for almost your hospital capacity to be tested to the limit. So we've seen we need to plan ahead in terms of PEP supplies, test kits, which we've had a lot of for, and we've coordinated with the national program. Staffing needs, oxygen, and trying to halt community transmission through the curfew that we've implemented in our region, and also trying to make sure people get vaccinated as much as possible. Thank you, Dr. Lois.
Thank you so much, Dr. Ogode. I think Siaya County is one of the counties we're really proud of. You've come a long way in terms of being prepared, and we recognize the role that you played even in just helping the county to get prepared. And the way you've managed to handle this latest surge is very impressive. And, you know, we salute you and your whole team. So thank you very much for that presentation. I think we'll allow just time for to answer a question that has been posted. We thank you everybody for giving us a few extra minutes. So there's a question that has been asked very many times, and I see it's also been posted here. And the question is around vaccine mixing. Now that people have heard, I don't know, Johnson & Johnson is coming, I don't know, Pfizer, I'm sure even some people here are thinking how they can go for one of those. So I'll just ask Dr. Maritim to come in and just give us a word on issues of vaccine mixing. Karibu, Dr. Maritim.
So thank you very much for that question around vaccine mix and match. And I know it's a very topical issue. And the data that we currently have around mixing vaccines is from two European clinical trials. So there was a Spanish clinical trial called CombiVac-S that the first dose was AstraZeneca and the second dose was Pfizer, and the interval between the two doses was 8 weeks. And it showed fairly promising data that it was safe and the immunogenicity was preserved. There are other ongoing trials in the UK. Actually, one of them has been, the results have been shared. And there's another one that's still ongoing. The UK trials, they're called COMCOV, comparing COVID-19 vaccine schedule combinations. And there are two, there's COMCOV-1 and COMCOV-2. COMCOV-2 is currently enrolling. COMCOV-1 already completed and already published their data. So in COMCOV-1, the first dose was AstraZeneca vaccine, and a second dose was a dose of Pfizer vaccine. And they tested varying intervals ranging from 8 weeks to 12 weeks. And in that trial, the findings were slightly different from the Spanish trial, where the vaccines were found to be immunogenic, so there were robust immune responses, but the safety or the adverse events reported was slightly exaggerated because we are looking at predictable adverse events where you're talking about pain at injection site, fever, headache, and really nothing out of the ordinary. But in the UK study, the number of reported cases of adverse events following immunization were found to be slightly on the higher side compared to the Spanish study, but there was nothing out of the ordinary. And what basically these two clinical trials suggest is that having a first dose of AstraZeneca followed by a second dose of Pfizer induces an immune response and is able still to provide sort of, in terms of the adverse events, nothing to really worry about. And when you look at why these trials have become important in this day and age, is because we know that in Europe, a lot of the settings following the reports of the clots following AstraZeneca, there was a shift to actually move a lot of people to a second dose of another vaccine, preferably an mRNA vaccines, and different countries already even gave the direction that they'll move that way, whether there was clinical trial evidence or not. But the trials that have been done show that you can mix the two doses. So looking, sorry, let me say something briefly about COMCOV-2, and then I just wrap up this issue of how would this be applied in our setting, given what the CS talked about at the beginning in terms of the plan to vaccinate a large number of Kenyans. In COMCOV-2 clinical trial, which is currently enrolling, this is really looking at first doses of either AstraZeneca first dose or a Pfizer first dose. And in the first arm where you have an AstraZeneca first dose, then you have 3 potential second doses. You can give an AstraZeneca second dose. In the UK, you can only receive AstraZeneca second dose or AstraZeneca even a first dose if you're 40 years and above because of the clot. So anyone under 40 years cannot receive an AstraZeneca vaccines based on their vaccine recommendations and the fact that there are different options of mRNA vaccines that are licensed and available in their setting. And then the second dose still within the arm where you receive a first dose of AstraZeneca is a Moderna, which is an mRNA vaccine. And they're also hoping to enroll some people who will receive Novavax, which is a protein subunit-based vaccine. It's not yet currently licensed, but it's undergoing registration within that jurisdiction. So the three potentials are a second dose of AstraZeneca vaccine, a second dose of Moderna, and a second dose of Novavax. The second arm is people who receive a first dose of Pfizer and then receive a second dose of Pfizer, Moderna, and Novavax. So you can see in terms of the two strategies, you may receive the same dose of first dose and second dose, but the other two permutations or introductions is Moderna, which is another mRNA vaccine, and Novavax, which is a protein subunit-based vaccine. And they're dosing the two vaccines at intervals of 8 to 12 weeks. So from the manufacturer's instructions, Pfizer is supposed to be dosed, the interval between the first and second dose is 21 days. But in this COM-COV2 clinical trial, they're stretching that dosing interval to 8 to 12 weeks, and they want to see the safety and immunogenicity of these vaccines, and we await that particular data. So having said all that, and that vaccine mix and match may be a possibility within our setting, I think from what the Cabinet Secretary mentioned at the beginning, there's a plan to vaccinate more than 20 million adults within Kenya. And the plan is to use a lot of J&J vaccine, which is a viral vector-based vaccine, which requires only one dose. And therefore, once we have J&J in our setting, the one dose would be adequate, and therefore even mix and match may not really be an option in that case. But he also said we are anticipating about 1.8 million doses of Pfizer vaccine. And looking at it, for Pfizer, you need 2 doses. He mentioned there was an initial 1.8, and then there will also be an additional 1.8. And therefore, it means for the Pfizer vaccine, it's going to vaccinate the 1.8 million doses is really an entire dose for only 1.8 million people. And therefore, we need to see who will receive the Pfizer vaccine from that. And he also mentioned that there would be enough AstraZeneca to complete a second dose for most of the people. So I think in our setting, there may not be a situation at this point in time for vaccine mix and matching, because all the people who already received their first dose of AstraZeneca, he also mentioned that there are about 400,000 doses for the remaining, I think 400,000 people who are due to receive their second dose. And then when we start deploying J&J vaccine, there'll be enough single doses for those group of people. And then Pfizer maybe would be prioritized, maybe for certain groups like pregnancy, because now we have data from the US that this mRNA vaccine in clinical trials that were enrolling pregnant women have been shown to have a fairly good safety margin. And therefore, maybe the Pfizer vaccine may be prioritized for certain risk groups for whom maybe there may be still outstanding safety issues around the AstraZeneca in certain groups of people. So I think those are just some of the comments I wanted to mention around vaccine mix and matching, what we currently know, and maybe implementation going forward. Thank you.
Thank you so much, Dr. Maritim, for such an excellent answer to that. I'll just give a 2-word answer for 2 questions that have come. One is that someone asked, should they go for third vaccine? Now that they've gotten 2 AstraZeneca, should they go for the third one? The answer is no. There is absolutely no evidence at this point for third vaccination. There's some work going on, but we do not know about it yet. And what we know that up to 1 year down the road, because we've only had people vaccinated longest for about a year, is that they still seem to have adequate responses in terms of antibody and cellular responses. So at this point, please don't rush for the third one. Allow everyone to get. The other question was around, what was it? Sorry, another very, very quick one. Has it disappeared? Or how effective is AstraZeneca against Delta? So against severe hospitalization, severe disease and mortality, it is effective. And we have very good data from the UK now that tells us that. So don't worry, you're safe if you've gotten your 2. If you're a healthcare worker and you haven't gotten your 2 vaccines, please rush. Don't sit there and wait. Rush and get your vaccines, okay? So thank you very much, everyone. Just one comment. Thank you very much, Professor Chokwe, for some of the answers that you provided to us. You've also provided a link that the Critical Care Society of Kenya has a half-day webinar tomorrow, which is free to attend, and will answer a lot of the questions that have been asked about oxygen. So there's a link provided in the Q&A. Please have a look at it, and if you can, please join that one. So thank you for giving us extra time. It's been an excellent webinar. I want to thank all the speakers, all the panelists who joined and are presented from their facilities. We are really grateful, and we salute you all for the incredible work you're doing with your patients. So we'll stop there. Have a lovely weekend. Goodbye, everyone.